Hello, welcome back. Today we'll be going through the physiology of fluid distribution and equilibrium. So, as you know, water is 60% of the body, and the cellular fluid, the intercellular fluid, composes like 2/3 of the total body water, while the extracellular fluid is about 1/3. So, within the extracellular fluid, the interstitial fluid is going to be 3/4 of the extracellular fluid, and then the plasma volume is going to be only 1/4. So a little confusing, but just know that the intercellular fluid is 2/3. Intracellular is different. Water goes in and out of the cells via just osmosis, and heavy water, so deuterium, will measure the total water in the body, while inulin and mannitol will measure the ECF. So blood volume, just to calculate it, is the plasma volume divided by 1 minus the hematocrit. So the only difference between osmolarity and osmolality is the units. So this is in liters, this is in kilograms. Molarity is the concentration of the solutes, while osmolarity is going to be the total amount of the solute in solution. The osmolar gap is important because it measures the differences between osmolarity and estimated osmolality, and that kind of gives you the equilibrium of whatever solute is in the body. And you use ethanol, methanol, ethylene glycol, or acetone, and mannitol to elevate the gap. So usually in cases like shock, or like blood loss, you want to elevate the gap in order to maintain equilibrium. So this is the solution. It's 2 times the concentration of sodium plus, this is urea, so BUN, divided by 2.8 plus glucose divided by 18. The expected sodium concentration is going to be the serum osmolality that is measured minus the urea minus the glucose divided by 2. So the DARROW-YANNET diagram is just the estimation of what's going to happen in the body if you fiddle around with the solute concentration or the volume. So the x-axis is the volume in liters, and the y-axis is going to be your solute concentration. On the left side is going to be the intracellular fluid. Outside, this on the right is going to be the extracellular fluid, and it helps you kind of like guide the thinking process, especially if there's something like what would happen if someone was stuck in the desert. So isoosmotic is normal, and if you were stuck in the desert, you'd be sweating, so your blood volume would be down, but your solution would be higher, so it would be the hyperosmotic. So the volume would decrease, so the bars would go inwards, while the solute concentration would increase, so the bars would go, or this box will go up, so it gets narrower and goes up. Another example is what would the DARROW-YANNET diagram look like during a hemorrhage. So in the hemorrhage is going to be sort of the same, but a little bit different because you would be losing volume, but you would also be losing some solute, because you'd be losing both essentially. All right, so if you look at the diagram, it would be you lose a lot of your extracellular fluid. That's the one that you lose the most, right? So it would go inwards here, and then this would go down. So the hormones that regulate blood volume, it would mostly be antidiuretic hormone, aldosterone, and renin. That all feeds back on each other using the negative feedback responses. But as you can see here, if you eat salt or you're dehydrated, your osmolality will go up. There's more salt concentration, will be higher. So that will cause thirst, and that would be drinking. But more importantly, it's going to increase antidiuretic hormones in order to retain the water that you're drinking. So the cellular membrane is going to be a barrier for sodium, while the capillary membrane is going to be a barrier for the plasma protein. And they're used for filtration and absorption. And the hydrostatic force will, force the water, the osmotic pressure, to equalize in order for equilibrium to be reached. So hydrostatic pressure pushes outwards, while osmotic or oncotic pressure pushes inward. Hydrostatic pressure is more related to blood flow. So you measure that in the venous pressure and blood volume. And oncotic pressure is due to the proteins, so they kind of build up and they can't pass the membrane. And the lymphatics maintain a low interstitial volume and protein content because proteins can pass through the lymphatics easily. Starling equation right here is the formula for fluid exchange. So this one, it's useful to know, but if they were ever questioned on it, they have to give you all these values. You can't just sit down and try to calculate it yourself, right? So you need to know the hydrostatic capillary pressure, the interstitial pressure, the pressure, the oncotic pressure of the capillary, and the oncotic pressure of the interstitial space, along with the coefficient of permeability. Well, that's a constant, but in order to find that, I really doubt you'd be tested on this, but you might be tested on what is the formula. You just say Starling equation. Okay, so there's two different types of edema. Pitting edema is when you push down on a patient's usually extremity, and you hold it for a little bit and then retract your finger. And if there is a little divot that remains, that's pitting edema. Non-pitting edema is you do that and there's no pit left behind. Peripheral edema occurs because there's going to be an increased capillary hydrostatic pressure, and that could be due to venous obstruction or heart failure. And decreased interstitial oncotic pressure, it could be due to thyroid dysfunction or lymphedema. Lymphedema is different because lymphedema can't really be treated. It's kind of like a problem in the lymphatic vessels itself. It's kind of genetic. And the only thing you can do really about it is to elevate the legs often and wrap them, or wear hose when you go to work. So they just kind of swell mostly in the lower limbs, and it's benign. It's just aesthetically displeasing, and there's some limited mobility. So the decreased vascular oncotic pressure can be due to some kind of liver disease or chronic kidney disease. And the capillary permeabilities are going to be affected. So TNF alpha, bradykinin, histamine, and cytokines will be released during diseases, infections, and whatnot. And usually pitting edema is a good thing, or edema isn't a bad thing, but pitting edema can be treated. Pitting edema, it responds very well to diuretics, so you can give diuretics and bring down the pitting edema fairly easily. Non-pitting is trickier because you can't just treat the pitting edema. You have to really locate the cause, and that might be lymphatic obstruction, or a strep infection, or a consequence due to surgery, and it could be cancer. Pulmonary edema is the most dangerous because there's a danger of hypoxemia and hypercapnia. So lack of oxygen and excess of carbon dioxide in the blood. Why is that dangerous? Carbon dioxide converts to it converts to carbonic acid, and that can acidify the blood. So usually the low hydrostatic pressure in the pulmonary capillaries and the lymphatic drainage will protect the lungs, and that's caused by cardiogenic pressure. So increased left atrial pressure will increase the lymph flow, and that will elevate the wedge pressure, and kind of like through pressure gradient, it's going to drain. Problem is when there's some kind of like non-cardiogenic cases, so adult respiratory distress syndrome, sepsis, trauma, pneumonia, and aspiration will cause pulmonary edema. And this is problematic because with the pulmonary edema, the alveoli aren't able to compress and expand like usual, so there's going to be some decreased oxygen intake. So there's the leak or ligand-gated channels, voltage or mechanically gated channels, and the important thing to know is the voltage gated channels are much faster than the ligand channels, but the ligand channels are more specific. So there's all these different types of transport. The only difference is exocytosis can occur in a non-constitutive pathway or a constitutive pathway, so it can be either regulated or unregulated. Exocytosis usually uses the V snare or T snare arrangement, where a snare protein will bind to a receptor, and these receptors need calcium in order for the fused area to break down and allow the vesicle to come in. So whatever snare protein this is going to bud off of an organelle, get attached to a transport vesicle, and then it's going to go and tether using a tether protein to a target organelle. Then it will dock, and then it's going to use the calcium in order for it to fuse and then release the products in. Endocytosis is a little bit easier because they use something called clathrin, which is a protein, and it just kind of works as like a net, like a fishing net, sort of, because you don't really throw it out, but whatever's floating around gets caught into it, and then it binds to the clathrin. The clathrin invaginates in this pit, and then with this pit, it closes off, and then next thing you know, scission occurs when the pit has bound, and then there is a transport molecule that surrounds it, and usually meets out of some kind of diamine, and then that's how the cell engulfs things, either through phagocytosis or penocytosis. And GTP is involved in order to pinch off the vesicle. And then what's nice is this is reusable because the clathrin is going to be removed from the newly made vesicle and then kind of like put back to the surface of the cell. Caveolate-dependent is sort of the same. It's a different protein, caveolin. It infiltrates the wall of the lipid rafts, and the phosphatidylinositol, line proteins, and using those are also embedded in the membrane, and that faces the lumen. And same thing, it goes through the internalization, and once things have bound to it, this is regulated by something else. It's just regulated by dynamin. And these are going to be prominent in the endothelial cells, where they help in the uptake of nutrients from the blood. As you can see here, it's the same thing. It reuses the cavin, and then they recycle the microtubules. There's these other different kinds of transporters. Ultrafiltration is when the oncotic pressure forces substances through the epithelium, and that's really only in the kidneys. The difference between a pore pathway is it's going to be open to some ions, small solutes, and small molecules, and there's not a lot of transport, right? It's like regulated. There's just not, it's kind of like a narrow pathway, while a leak pathway is going to let a lot in and out. So this is more in like axons and stuff, allowing the action potential to occur. Okay, there's all these different kinds of communication. Juxtacrine is just like a new type. I don't know if you did Histo 1, but in Histo 2, you learn that juxtacrine needs like physical attachment in order for it to communicate. The rest are just kind of like molecules, right? But only in juxtacrine it's contact dependent. Okay, that's it for now. Thank you for your attention and good luck studying.